Dr. Satanshu MATHUR is a very renowned surgeon from Uttarakhand, and he's a very big hospital, and he's a very active member in the the Uttarakhand Ophthalmic Society, even AIOS also, and the North Zone Ophthalmic Society also. So he's going to talk on complex posterior polar cataract.
Thank you, Rajinder. Thank you all the organizers of this conference. So posterior polar cataract is an entity that is always a headache for the even for the specialist phacosurgeon. But if follow simple tips and tricks, we can achieve a high success rate even if there is a pre-existing break. So I am just showing the two videos. There are 8 tips and tricks. This is a preoperative evaluation is very important in posterior polar cataract because onion-like structures is there. You can see the rings. You have to differentiate it from the posterior subcapsular cataract, and you should keep in mind that in 33% cases of posterior polar cataract there is posterior capsule deficient. So always plan surgery with the vitrectomy ready. So this is how we can plan our surgery. Every procedure has to be very slow in such cases. All the rules should be followed. We should not make a shortcut. Dye, even if cataract is very soft, even then we should inject the dye to clearly see the margin because we have to make a small axis. And we are making an oval capsular axis. This is the first tip is the slit lab examination proper. Second tip is the oval capsular axis. Oval capsular axis always helps. This is developed by Dr. Karanjit. This always help in removing the cortical matter in the superior part and also the nucleus manipulations. So oval capsular axis is really very important in such cases. But it should be small but adequate. And important tip is this. There is no hydrodissection. We are just cracking the nucleus in center without hydrodissection, as the nucleus is soft. And this is the important thing which I am going to show you. Now we are doing hydrodissection on the one side of see. So we have divided nucleus cracking, and then after cracking we are injecting the fluid inside this nucleus. The fluid will never go behind the cataract, never go to the posterior capsule. So this is the trick. The inject after the dilation in the division what we have made, and we can achieve the ring. You can see that we have achieved the ring. So it is very safe. Nothing is going to behind the posterior capsule. Tip 6, all parameters should be low. Second instrument is very important because we are manipulating the nucleus mechanically, lifting it, dividing it, because rotation is not advisable in such cases. So second instrument always very helpful. Nucleus are soft, can be easily manipulated. So just hold by the phaco. Then once you have achieved, important tip, AC should be maintained. We should never remove the main phaco probe without injecting viscoelastic from the side port. We should never allow the chamber to collapse. This is tip number 6. And now comes the irrigation aspiration. So bimanual always safe because it is very slow procedure. We are not to increase the pressure inside the eye. Botal heights etc. should be very low. So all the maneuvers, just pull it, radial pulling, bring in the center, and then raise. Again injecting viscoelastic before removing the instrument, and now doing IA from the other side. Because we always take chance of pre-existing capsular defect in such cases. So once you have done, then again injective viscoelastic, chamber is formed, and we can do. In short, so I am showing to other video. In short, this is the case after the surgery. This is another case where there is a pre-existing defect behind. We have seen on the slit lamp. So now we have to be more careful. Every procedure has to be gentle. Gentle hydrodissection is done. The cannula we are using, this is the cannula we are using. It has not the flow on the tip, but from the side. When there is a flow from the tip, it goes behind the posterior capsule. So it has side port. So when you inject the fluid, it will never go behind the posterior capsule. So this is hydrolysis with modified cannula. No fluid from the tip but from the side, and will never go behind the capsule. It will remain inside the nuclear zone. So gentle hydrolysis is done, no hydrodissection. Now no cracking, just crack the nucleus. Do not rotate it. Crack it, crack it. Do not rotate the nucleus because rotation will increase the posterior capsular defect. All the maneuvers should be gentle, bottle height should be low, phaco power should be low. Have patience while you are dealing with the posterior polar cataract instead of wasting time later on in managing the complications. And every anti-segment surgeon should keep a vitrectomy setup ready whenever they are dealing with the posterior polar cataract. You are not lucky every time to be 100% safe. So all the maneuvers should be gentle. Epinuclear shell is removed in the last because it protects the defect. Where the defect, epinuclear shell is there, so you remove it in the last, gently pulling it in from behind the anti-capsule into the center and then removing it. I'm just moving fast forward. So you see there is a defect in the posterior capsule. You can see there is a defect in the posterior capsule that was pre-existing, and by doing all this surgery this defect has not increased because we have taken all the precautions. So this is very important to take all the precautions. Even if there is a pre-existing defect, it will not increase, and you can put the lens in the bag, whatever lens you want to push. Good. So vitreous space is intact. So thank you very much.
Excellent. Satanshu.